Good afternoon. Thank you very much for inviting me to be today with you on this interesting conference. I'm Dino Hadzic. I'm talking to you via pre-recorded talk from London. I was asked by SPCAN Hepatology Committee to tell you a few words about neonatal cholestasis, which is relatively common problem for the hepatologist, but not a very common problem for general pediatricians, I presume. The first thing which I would like to stress here is the significant difference between the understanding of the etiology of prolonged neonatal jaundice back from 2000 in comparison to 2020. And you can see on this slide that we understood much less about causes of neonatal jaundice, calling them idiopathic in almost half of the patients, whilst 20 years later we have significantly reduced that proportion, and now we understood much more about that, really thanks to the increased understanding of the genetic causes of neonatal cholestasis. Now, clinically, what we do whenever these patients are referred to us, we go through conventional medical items from history, clinical examination, laboratory tests, ultrasound, and very often we would consider doing liver biopsy. Blood tests these days are, in addition to standard tests, are enriched by the addition of genetic tests, and particularly what we call mutation panel analysis, which is common for a number of pediatric subspecialties. So for us in liver disease, we have cholestasis gene panel, we have acute liver failure gene panel, and I'm sure other colleagues in other subspecialties of pediatrics will have the similar experiences. Causes of cholestasis are fairly diverse, and I put a very, very brief table really reminding us that there are some primary causes for cholestasis and some secondary, and in general pediatrics we are much more likely to come across the secondary causes of cholestasis, such as infections, sepsis, gallstones. Sometimes lack of enteral feeding could be the reason for the cholestasis, hematological conditions, chronic hemolysis, etc. What I find helpful is this algorithm where we have tried to put together how we investigate the infant with the cholestasis on the top. So key element in our assessment here is circled in red, appearances of the stools. So if the stools are pale or not pale, the difference in the diagnostic algorithm is significant. Very important element in the discussion is also serum gamma GT level, one of the liver enzymes called gamma GT, which in certain forms of familial cholestasis is very low and or normal. In the past, the major part of the workup would have been always liver biopsy, but in the recent couple of years, the biopsy has become less popular because its perception is that it's too invasive, and people, in order to try to distinguish between anatomical and medical causes of the cholestasis, are probably more relying on cholangiography. I will say a few words about that in a second. But majority of these patients would be really going through these various genetic panels where many of the conditions could be diagnosed, some of them with high gamma GT, some of them with low gamma GT, and very exceptionally we would still need to use a very sophisticated biochemical tests such as urine mass spectrometry to diagnose primary bile acid synthesis defects. So in the context of so-called familial cholestasis, progressive familial intrahepatic cholestasis, so-called FIC, the commonest condition you might come across are so-called BSEP deficiency, people also call it as FIC type 2, or MDR3 deficiency, also known as FIC type 3. The other conditions, and they appear to be really discovered, maybe on an annual basis, so the list is getting longer and longer, are much less likely to be encountered in a general pediatric practice or in primary gastroenterology. Now, what I would like to say a few words about is a condition called biliary atresia. And if we look things in the context of neonatal jaundice, which is obviously very common, the first thing which we need to distinguish is whether this jaundice is conjugated or unconjugated. And clearly for us in hepatology, the important is this green circle denoting conjugated jaundice. And within that circle, there is a condition called biliary atresia, which I think it's worth discussing in a little bit more detail, because this is a condition which where prompt diagnosis makes a significant difference to the outcome of these children. Now, back to the basics. This is really something which I would like to remind all of us, that the key in investigating these patients is looking at the appearances of the stool, normal on the right and acholic, hypocolic on the left. And clearly the left type of stool is more indicative of potential anatomical or surgical causes of neonatal cholestasis. Biliary atresia is defined as progressive cholangiopathy of unknown etiology affecting both extra and intrahepatic biliary system, and if left untreated, it leads to biliary obstruction, biliary cirrhosis, and death, usually in the second year of life. Biliary atresia is the commonest cause of chronic liver disease globally, and it's also leading indication for liver transplantation in pediatrics. The condition is relatively sporadic. There is no really known genetic element, and it can be it's estimated to be detected in probably about 1 in 8 to 16,000 live births. Such a wide range is described, and in terms of difference between incidence of biliary atresia in Far East, countries like Taiwan, China, Japan, and Europe and North America, where the incidence is more like 1 in 16,000 live births. No one really knows what's the reason for such a significant difference. There is no gender predominance. Biliary atresia has been described in twins or triplet pregnancies affecting one child, but other twins are unaffected. The pregnancies with biliary atresia usually are uneventful term, and the baby appears initially very well, albeit slightly jaundiced. And there is also no significant clustering of the cases, so no really suggestion that there is a seasonal pattern which could be related to some viral infections or something similar. We generally divide biliary atresia in two types. One is acquired, the other one is congenital. Acquired, also called non-syndromic, is seen in probably about up to 90% of the cases, while syndromic or embryonic, where people think that the disease has started before the birth, is seen in something like 10 to 15% of the cases. Typical histological appearances are like this. This is a liver biopsy sample stained in H&E with expanded portal tracts with the intrahepatic bile plugs, with a reduplication of the biliary system and incipient fibrosis, which clearly can be very, very serious in due course. The diagnosis of biliary atresia is not always easy, and often we need to repeat liver biopsies. Sometimes, if we want to prove that there's a pigment in the stools, we can use HIDA scan as a perhaps time-buying measure. Often the patient needs to be primed with phenobarbital for 5 days before the procedure. Some people have described bile sampling as possible. If you detect bile sample in the gut, you're probably not talking about biliary atresia in the context of cholestasis. On ultrasound, some radiologists have described triangular cord sign reflective of fibrosis in the liver. But these days, if you're lucky to have facilities for endoscopic retrograde cholangiography, so-called ERCP, that would be ideal way to diagnose in ambivalent cases biliary atresia. The ERCP is not commonly available, particularly you need to have a very small scope, and many centers would go directly to so-called intraoperative cholangiography instead. This is the picture where the ERCP has actually shown the patency of the biliary system. This is ERCP cannulation, where you can see intrahepatic left and right branch and with the gallbladder. So this child, in the end of the day, turned out to have Alagille syndrome rather than biliary atresia, and never needed surgery for that. And talking about the surgery, this is the conventional surgery for biliary atresia, so-called Kasai portoenterostomy cartoon, where the surgeon takes usually about 40 centimeter length of the bowel and attaches that to the liver, and then reattaches that for the rest of the bowel. So it's Roux-en-Y loop, which seemed to be the first line of the treatment for the babies with biliary atresia. The results of that surgery are relatively good in that about 2/3 of the children clear jaundice by 6 months. However, 1/3 needs liver transplantation before age of 2 years. About 2/3 of the children will eventually, during the childhood, require liver transplantation. But the fact, which clearly is the most important when we're talking about biliary atresia, is that earlier surgery leads to better outcomes. And this is why I would like really to remind everyone to this possibility to keep in mind when handling children with prolonged neonatal cholestasis. In that respect, one very good and is a public policy is trying to use infantile stool color cards that are given to all newborn children in the delivery rooms, and parents would report on the appearances of the stool clearly from abnormal to normal if they have concerns, which not only helps diagnosis of biliary atresia, but also some other chronic liver conditions presenting at similar age group. Pathogenesis of biliary atresia is by and large unknown. The concept is that there are various potential insults leading to pro-inflammatory reaction in a susceptible host. Some people believe that that could be autoimmune in the background, but we don't really have very much evidence for that, except to say that even in the mouse model, we can see that there is a very, very strong reaction of the immune system, very pro-inflammatory Th1 type reaction with interferon gamma as a key cytokine, which leads to injury of the biliary tree. When we talk about inflammatory reaction, which is undoubted in biliary atresia, the logical thing to try to help to contain the inflammation would be to use the steroids. And we tried steroids a couple of times in the randomized studies. This is our study from many, many years ago, but we have not been able to see any positive effects on the outcome of biliary atresia. We did see some improvement in clearance of bilirubin. Similar result was seen by the study from Germany sometime later. So our aim when we are talking about neonatal cholestasis and particularly biliary atresia is to try to make earlier and correct diagnosis, which is not always easy. We would like really to understand the pathogenesis of biliary atresia a bit better, and particularly the syndromic forms, so-called biliary atresia splenic malformation forms, could give us some pathogenic clues for that, but so far they have been not really terribly helpful. And finally, to improve the prognosis of biliary atresia, we could potentially manipulate the response of the immune system by targeting our pro-inflammatory system with the various selected treatments which are becoming increasingly available these days. So that's the hope that will be improvement for the treatment of biliary atresia. So on that note, on that positive note, I would like to finish my talk and wish you all the best for the rest of your conference. Thank you very much.